Charge. Dah lah, aku dah start swimming. Muak-muak pula. Nak charge please. Cepat. Wow, bagus sis. Dah mandi. Cemerlangnya. Semalam. Dah pukul 3 kau balik bilik. Dekat bilik kau ada internet kan? Duduk. Datang sini boleh.
Assalamualaikum and good morning everyone.
Waalaikumsalam. Good morning, Doctor.
Assalamualaikum.
How are you today? Everyone's good. Semua kat college kan?
Yes, Doctor.
Any other any cases ke dalam college?
Setakat ni tak ada, Doktor.
Setakat ni tak ada.
Ya. Kan ada yang dah balik kampung ni.
Apa dia?
Ada yang dah balik kampung lah ni.
Ada.
Main awal macam nak tolong pasal langsir ke apa ke. Alright, okay. So without further ado, we start our class for MNT for legal. And I have to say that I'm sorry I have to turn off my camera because I'm at home quarantine with my kids, so I don't want any sights of inappropriate situations you can see from your screen. Okay? Alright.
Okay, Doctor.
Yang duduk kat college ada lagi ke?
Ramai.
Oh, ramai. Yang balik pun adalah.
Yeah.
So yang kat college tu dah buka ke the pasar Ramadan tu?
Dah.
Banyak ke yang buka kedai?
Boleh lah.
Cukup lah makan.
Cukup.
Okay. Alright, so okay. Okay, boleh nampak
Boleh.
Okay, so last week you have learned about the pathophysiological types of liver disease, how it happens, the risk factors, and how it affects nutritional status. Okay, so today we will proceed to the nutritional assessment for liver patients. Okay, and then the possible nutritional interventions for liver patients, and also you will learn more on the pancreatic disease patients. All right, so what is nutrition assessment? Why is it important? Okay, for liver disease, because you know that malnutrition is common common to happen among liver disease patients. Okay, but the nutrition assessment for patients with liver disease is complicated because there is no other indicator, sole indicator that can determine and entirely accurate and predict the degree of the nutritional compromise for the patients. So these are the factors that could affect the interpretation of objective nutrition assessment parameter in patients with end-stage liver disease. So when we say end-stage liver disease, we know that they are prone to get cirrhosis, ascites, okay, and because of the presence of ascites and cirrhosis and also edema, so meaning that this will mask up their actual weight, okay. So maybe the moment you see them, their weight is about, let's say lah, 60 kilograms. And then you pun bagi all the appropriate interventions. After a week, you see, oh, there is an increment. So you say, oh, Alhamdulillah, my diet regime is successful. But it might be not, because if the patients experience ascites or edema, or could be you see the patient at this weight like maybe 50 kilograms, 80 kilograms. So you propose that regime. One of the goal is to maintain or to lose some weight, okay. But then when you see this patient another 2 weeks or 1 week, you see there is a weight loss, okay. So it might be not the actual weight loss which comes from the body fat, but it could be coming from the fluid, okay, because they are on diuretic use, okay. And that's why the anthropometric measurements, it is questionable in terms of the sensitivity, specificity, and also reliability, because of these clinical conditions that are more common in ESLD, and there are multiple sources of error. Because normally when you go to the clinical settings, it doesn't need a dietitian to do the anthropometric measurements like height and weight, but it can be any healthcare professional. So in terms of the skill, okay, and then the equipments used, whether it has been calibrated or not. So these are the multiple sources of error that could contribute to the weight measurements or the height measurements, for example. And then the reference that we have to not account for variation in terms of the hydration status and also skin compressibility, right? And then for parameter like nitrogen balance studies, which the nitrogen is retained in the body in the form of ammonia. And for those who have a hepatorenal syndrome, it can affect the excretion of nitrogen. So it doesn't necessarily saying that this patient having poor nutritional status because of the low nitrogen balance, okay. And then with the use of single frequency of BIA, so this is invalid with the presence of ascites and edema. So you need to be accompanied with other equipments, for example, skin fold thickness, and then you could also use your skill in interpreting the physical examination through NFPF. So it should be coming together in a group of few methods to ensure that to say that this patient is having poor nutritional status. It's not only depending on one single parameter, okay. So according to this study in 2015, they said that there is no consensus among authors as to which are the most effective methods for assessing nutritional status of these patients, as the disease itself affects the values obtained. So the most frequently used methods include anthropometric parameters such as weight and height to calculate the BMI, mid-arm circumference, tricep skin fold thickness, to calculate the arm muscle circumference, arm muscle area, and arm fat area. So analytical parameters like albumin, prealbumin, transferrin, TLC, total cholesterol, creatinine, and protein will help to identify malnutrition and also liver dysfunction. Other methods used to assess the nutritional status in cirrhotic patients are SGA as well as hand grip strength, which is assessed by the use of hand grip dynamometer. BIA is also used despite the fact that some authors do not consider it very useful in patients with edema and ascites, or carrying out dietary assessments using tools such as MAST or NRS. Okay, so these are the types of parameters that you can use to evaluate someone's nutrition status, not only depending on single parameter. So the goal in nutrition assessment is to identify patients who are either at nutrition risk or already compromised, so that the determination and implementation of appropriate care plan can be done. Okay, so nutrition assessment is important for all liver patients, and also they need to undergo nutrition screening. So this nutrition screening is a process of using data which includes from the oral intake, biochemical parameters, anthropometric, to assess a patient's risk of developing malnutrition. So nutrition assessment is more comprehensive than screening and has been defined by ASPEN as a comprehensive approach to define nutrition status, which use medical, nutrition, social history, physical examination, anthropometric measurements, and laboratory data. So in the clinical settings nowadays, there are few types of nutritional screening that can be used by any of the healthcare members, not only for dietitians, okay, untuk nak tengok semua patients yang datang, but all healthcare members can actually learn and know how to use nutrition screening, because nutrition screening is just a simple survey, okay, that can be asked to the patients and also can be evaluated by the healthcare professionals, right? So a properly conducted nutrition assessment provides a global assessment of both nutrition status and the severity of the underlying illness.
Right.
So the assessments include history and also dietary intake, assessment of the body composition, and also biochemical assessment. Okay, so for biochemical tests of hepatobiliary functions, there are few types of serum enzyme tests, and most of these serum enzyme tests will be elevated, especially for those who are having liver injury or liver disease. For example, ALT, AST, okay, and the liver synthetic capacity also can be reflected in the measurement of serum protein levels and prothrombin time. So prothrombin time is important for the synthesis of coagulation factors to know whether the the patient, whether there is an impairment in terms of the blood clotting. Okay, and hypoalbuminemia can be caused by depressed synthesis, which may complicate the severity of liver disease. Like serum bilirubin, GGT, and also ALP is a measurement of hepatic excretory function. Meanwhile, ultrasonography and CT scan and also liver biopsy also can be used to determine the diagnosis or the severity of the liver function. Okay, other serum proteins like prothrombin, serum albumin, serum globulin, and then there are also some markers of specific liver disease like serum ferritin, ceruloplasmin, alpha fetoprotein, and also alpha-1 antitrypsin. Okay, and these are the tests for viral hepatitis, and also machine learning tests like for the determination of ammonia level in the blood. Okay, so for the assessment of dietary intake, so normally we'll do history on their oral intake through 24-hour recall, FFQ, and also food dietary. And there are few factors that could contribute to that history. For example, the past dietary restrictions. Maybe the doctor has recommend or advised this patient to restrict for certain nutrients or certain supplements. Okay, and then their appetite level, their satiety levels, because of the abdominal distension that they experience, okay, because of the ascites. So somehow this patient might experience early satiety, okay, and then taste changes, the supplements used, allergies towards any foods or intolerance to any types of food, okay. And then from the SGA, which is the subjective global assessment, it can be used to predict nutrition risk using a score which is based on the weight changes, whether it is less than 5%, within 5 to 10% of more than 10%, which is a severe one, and then their intake, whether there is an improvement in terms of the appetite, okay, in terms of their intake, okay? And then the GI symptoms, whether there is a presence of diarrhea, nausea, and any physical signs of malnutrition. Okay, and this is the types of tools to assess energy intake in ESLD. Like for example, here's 24-hour day recall. So this one is easy to use and it can estimate the usual dietary intake. So the strength it is low cost, quick, and no equipment required. But however, there are few limitations. For example, because it depends solely on the memory capacity, okay, of the patient. So if the patients are ESLD and having NCAF, so it might be a problem to determine their dietary intake using this 24-hour day recall. And then underreporting also can occur, okay, in terms of the portions and food items consumed, okay, especially between those with different BMI levels. And then food frequency questionnaire. So this one is a given list of food or beverages and to indicate how frequently these foods are consumed. So this one is low cost and quick to be used. But however, the limitation, it does not represent the foods that are typically consumed, and it requires a high level of patient literacy and does not provide data on portion size or actual protein energy intake. Okay, and then food diary. Food diary, which the patient or the caregiver need to record the food that they have consumed. Okay, so this one does not require any special equipment, can be very accurate, and it is low cost. But however, the limitation is that it requires instruction by the provider and it relies on the nursing staff to complete this food diary if the patient unable to fill in himself or herself, and then it requires a high level of literacy to write and also to read, okay, and then it is subject to the understanding of the patients on how to estimate the portion size, the quantity, the ingredients used in the food. So it will lead to inaccuracy. And then it typically will underestimate energy intake. So this one is common. If I ask you, what did you eat last night? So you akan kata makan nasi. So when I ask you, how much you eat? Mesti you pun akan mengecilkan dia punya portion size. You don't say that, oh saya makan bertambah sampai 2 kali. Tak. Biasanya people will underestimate. Not underestimate, will underreporting, which further will lead to underestimate the energy intake. Okay. And second one is the assessment of body composition. So there are many changes that could happen in the body composition of patients with ESLD because of the malnutrition they experience, the presence of ascites, edema, and which could actually mistakenly with their the weight changes, okay. And then for individual with cirrhosis, it has been shown that they have an increase in terms of the extracellular and also decrease intracellular fluid compared with the healthy individuals. And then a decrease in muscle mass and adipose tissue is often present, but not always apparent, as it may be masked up by the fluid retention. Okay. So, according to Peng, it found that a significant difference in protein conservation in men compared with women. So men lost an average of 20% of their body protein stores compared with only 11% in men and in women. So significant protein depletion was seen more than half of the study participants. So those with higher protein depletion had significantly decreased bone density, hand grip strength, and also respiratory muscle strength. So it is important to recognize the potential changes in body composition to properly assess nutrition status of the patient and make appropriate nutrition recommendations. So changing in body composition have been shown to progress with the course of liver disease and correlates well with the Child-Pugh score, which consists of 5 clinical features, and it is used to assess the prognosis of chronic liver disease and also cirrhosis. Physical examination, which include assessment on the muscle, adipose tissue, oral cavity, skin, hair, and temperature, is always one of the method that can be used and then can be complemented with the use of other methods as well. So it is often difficult to accurately identify malnutrition and body composition changes in cirrhotic patients who have ascites and edema, because again, the fluid weight gains mask up the muscle and adipose tissue losses. Okay, so the visualization of muscle wasting can be seen evidently in the temporal, clavicular, and scapular regions, which this area are typically less affected by fluid retention. So that's why this NFBF or physical examination is really important. Okay, and tools, there are few tools also available to assess or to aid in the assessment of body composition, which includes skin fold measurement, DEXA, hand grip strength, body cell mass, and BIA. However, some of these tools may not be readily available at the clinical settings, and their accuracy also may be limited in the presence of fluid retention. Okay, this one you can read yourself. As you can see here, actually DEXA is the gold standard test, okay, because it can assess body composition through a low dose X-ray. But however, the limitation is not readily available at the clinical settings, okay, and it is expensive. It requires high skilled personnel to conduct the assessment procedure. Okay, biochemical assessment. So commonly, previously, prealbumin and serum albumin are considered as indicators of nutritional status because these two markers are produced in the liver. Okay, however, due to the location of their synthesis and response to the inflammation, the value of these two biomarkers as an indicator of nutritional status is poor, particularly in patients with advanced liver disease. So it won't be accurate nutritional indicators, but it can be used as markers for the prognosis, morbidity, and also mortality. So ASPEN 2020 highlighted the role of prealbumin and serum albumin as inflammatory markers associated with nutrition risk in the context of nutrition assessment rather than with malnutrition per se. So meaning that we know that there is an increase in the level of prealbumin and albumin, not only to say that the patient is having a poor nutritional status, but it's actually in response of inflammation that this patient is having. Okay, and then there are also other tests that can be used to, for example, to see the function of hepatic excretion through the serum bilirubin, unconjugated bilirubin, direct or conjugated bilirubin, and then from the hepatic serum enzymes like ALT and also AST. Okay, so these are the things, these are the lab tests that are commonly used to determine the severity and the functionality of the liver. Okay, last one is NFBF. So this one, normally we use the SGA, Subjective Global Assessment of Nutritional Status, which is a measurement on this one is actually can be filled up by any healthcare professionals, okay, and then it also require to ask the patients in terms of the weight changes, how much weight and how many percent of weight loss, and the dietary intake, if there is any changes, how long the duration of changes, and then is there any changes in terms of the type of diet, whether liquid diet, full liquid, and hypocaloric liquids, and then GI symptoms, whether the patient having nausea, vomiting, diarrhea, and also this will require the healthcare professionals to ask directly to the patient. And again, it depends on the severity of the patient. If the patient is having hepatic and CAF, which actually we know there'll be an alter in their mental state, so it can be difficult to obtain the histories from the patients. Okay. Okay, this is the things. And this one, next is the NFPF. Okay, so these are the parts that you can examine to see for any loss of muscle mass. Okay, for example, to see loss of subcutaneous fat, you can look at these three area below the iPad. Okay, and then biceps area and also the triceps area. And then for to determine for any muscle wasting, these are the 9 sites that you can look through, like the temple, clavicle, shoulder, scapula, interosseous, and the fingers, quadriceps, knee, and also the calves. Okay. Okay, hold on, give me like 10 seconds. Okay, sorry. Alright. So again, in assessing nutritional status in liver disease, especially for end-stage liver disease, there are a few challenges in optimizing the nutritional status. For example, the difficulties in assessing the body composition, inadequacy of equations available to predict energy expenditure, and then the patient related itself, like for example, poor appetite, which could contribute to poor nutritional status. Okay, and then last one, the pathophysiological consequences of the liver disease. For example, alter in the macronutrients, metabolism, energy expenditure with the disease progression. So these are the challenges that a dietitian could experience in assessing nutritional status and to determine a proper diet regime for them. So because you know that malnutrition is common in liver disease and it gets worse with the severity of the underlying liver problem, and the poor nutritional status will then associated with very poor outcome. So because of that, nutrition screening, assessment, and also intervention are critical in improving the clinical outcomes. So therefore, early and adequate nutrition can help to minimize the effect of malnutrition. That's why the nutrition screening is important, a part of other methods. Okay, that's why in clinical settings there are a few types, like for example the one I show you, the SGA, and then now we have the latest one, but it's not yet to be used in Malaysia, which is called the nutrition prioritizing tool. So this one can be used for liver disease because it has a include indicator on the presence of ascites edema, which is quite common among end-stage liver disease. Okay, so that one I'll share with you the articles on the RFH and PT tools. Okay, next we proceed to nutritional guidelines in liver disease. So according to Aspen, okay, so we refer to Aspen and also ESPEN, okay. So the energy requirement for liver disease is between 25 to 40 kilocal per kilogram daily. But without NCAF, it is between 25 to 35. With NCAF, it is 35. And for those who have stable or compensated liver disease, okay, and malnourished, so we'll be giving them 30 to 40. And all stable cirrhosis patients, according to ESPEN, it is 35 to 40 kilocal. Okay, so the energy requirement is determined for patients are based on the severity of cirrhosis and the presence of ascites, hypermetabolism, or malnutrition. So all experts in the field agree that compensated stable patients, compensated meaning that they do not portray any symptoms or they are non-symptomatic. So they have energy requirements near to normal, with more critically ill patients having a higher requirements. So for well-compensated patients, it could be between 25 to 35 of energy is appropriate. But who are malnourished, they require between 30 to 40 to promote anabolism. Okay, so ESPEN also recommend a much higher energy intake should be focused on the prevention and treatment due to prevalence of malnutrition. So the estimated the weight that you could use in order to estimate energy requirement is using the estimated dry body weight, the weight without fluid retention, or ideal body weight. And then for the protein requirement, Aspen recommended for those without NCAF between 1 to 1.5. And then for ESPEN, all stable cirrhosis patients between 1.2 to 1.5. For ICU malnourished patients who are at risk for refeeding, 1.2. ICU for the maintenance of caloric support, 1.5. And for the critically ill obese patients, it should be between 1.5 to 2.0. So according to SWOT, they said that minimum protein requirements of adults with cirrhosis are 60 grams daily, or about 1.2, within the weight of 30 kilograms. And then it is based on nutrition balance studies. But in the settings of sepsis or varicose bleeding that could happen to them, the protein requirements could be increased up to 1.5 to 1.8. For lipid, in cirrhosis, the plasma, FFA, glycerol, and ketone bodies are increased during the fasting state. Okay, so an average of 30% of energy intake on the dietary fat is sufficient for those who need additional calories. And in patients with severe steatorrhea, so the use of MCT oil should be considered to them. For carbohydrate restriction is not recommended for patients with cirrhosis because of the high prevalence of insulin resistance and diabetes in these populations. So an intake of about 50 to 60% could help to prevent hypoglycemia. So how about vitamins and minerals? So as the liver disease progresses, the presence of portal hypertension leads to the development of ascites and also peripheral edema. So patients with cirrhosis and ascites should have a moderately salt-restricted diet with daily salt intake of no more than 5 to 6.5 grams. Okay, so this strategy has been shown to be effective in more than 90% of patients achieving a reduction in the volume of ascites to acceptable levels. So vitamin and mineral supplementation should be considered for all patients with ESRD because liver has the function of one of the function of the liver is the metabolism of all most of vitamins and minerals. So if there is an impairment in the functions, of course there will be an impairment in terms of their assimilation of these vitamins and minerals. And then fruit restriction to 1 to 1.5 liter per day should be reserved for those who are clinically hypovolemic or excessive fluid in the blood with severe hyponatremia, which is less than 125 millimole per liter. So in terms of the interventions, so it is advisable for them to have a proper meal timing. Okay, studies found that early breakfast improves cognitive functions in patients with subclinical hepatic encephalopathy. Sorry ya, ada background sound. And then it is also advisable for patients, okay, to avoid fasting because fasting of longer than 3 to 6 hours during daytime could actually make the symptoms become even worse, and also they will experience more poor nutritional status. Okay, and for cirrhotic patients, fasting of about 10 hours is actually equals to 3 days fasting in a patient with healthy liver. Okay, and then small and frequent meal is recommended for them, and it should be evenly distributed throughout the day so that they could get benefit from the caloric distribution, okay, throughout the day to avoid hypoglycemia. It should have 3 main meals and also 3 snackings in between. And then for bedtime snacking, also it is recommended, which should be contain at least 50 grams of carbohydrate complex to improve their protein stores, and sodium restriction for less than 2 grams of sodium a day in the presence of ascites and edema is recommended for them. The next is liver transplantation. So whenever the liver functions is becoming very less, which is less than 10%, so transplantation is always recommended for them. But how to ensure that they have a good nutritional status prior to the transplantation procedure? Okay, for pre-transplantation, according to this study, energy balance was negative in all patients, but significantly worse in patients with child-pure class C liver disease. So for the pre-transplant patients, nutritional status, hemoglobin levels, and also disease severity were dependently associated with the number of infection episodes during the hospital stay, and that malnutrition was the only independent risk factor for length of stay in the ICU. So BMI extremes were significant predictors of death. So pre-transplant who are obese are more likely after surgery to have primary graft dysfunction, which could delay the graft function, and they could have a higher risk of death. So, but however, not only being obese, for those who are being underweight, they also will have significantly lower survival according to the study. So weight loss is have been advocated as a way to reduce the amount of liver fat among obese patients, and therefore will help them to improve their nutritional status prior to the major surgery. And then low muscle mass. According to the study, they said that low muscle mass, as determined by the CT scan, was strongly associated with post-transplant, which according to the length of ICU stay, total length of hospital stay, and number of days requiring intubation. So this effect was modestly seen in women and quite strong in men. So the impact of nutrition on cirrhotic patients awaiting for liver transplantation is that for food intake, okay, a low spontaneous energy intake is associated with highest mortality. And then an introduction to probiotic will help to prevent post-liver transplant infection and help to improve minimal hepatic and CAF. BCAA, branch chain amino acids, also have been used in many studies and has been said to improve the nutritional status, hepatic NCAF, glucose intolerance, liver regeneration, and to promote a healthy quality of life. And nocturnal meals or the bedtime snacks also is said to improve total body protein among the patients. And then during the immediate post-transplant, the first 2 post-transplant months, nutrition needs are increased to promote wound healing, to deter the infection, provide energy for recovery, and to replenish the depleted body stores. So during the time, nitrogen requirements are elevated, and it is improved with early post-operative enteral nutrition, and it therefore can reduce the number of infections. Okay, administration of probiotics and fiber in the tube feeding may reduce the post-operative infection rate better than tube feeding or fiber alone. For acute post-transplant, early enteral feeding is indicated for them. So within the 12 to 24 hours post-operative, so you should introduce enteral nutrition or normal food if the patient can eat orally. Okay, and then for the energy requirement, it is recommended to be given 35 to 40 kilocal per kilogram body weight per day, and for protein recommendations between 1.2 to 1.5. So for the feeding route, it is used for early enteral nutrition, whether to use nasogastric or jejunostomy, depending on the functionality of the GI tract. Okay, and then the type of formula used, like whole protein formulas are recommended, and for patients with ascites, concentrated high energy formula are recommended for them, and for patients with NCAF, any formula with BCAA enriched are recommended for the patients. Okay, and for the long-term post-transplant, so this one showing that findings from few studies. Okay, for example, in this article published in the ISPEN, in malnourished patients, nutritional status further deteriorated at 3 months but improved at 6 and 12 months after transplantations. And the fat mass significantly increased from before to 12 months after the transplant, while parameters of muscle mass showed minor variations. And the daily calorie intake also improved, and protein intake also are increased for them. So in patients without malnutrition, nutritional status and dietary intake showed minor variations after transplantations. Hyperinsulinemia was normalized, and insulin sensitivity improved in all patients after the post-transplantation. And in this study to look for metabolic syndrome after liver transplantations to see the prevalence and the predictive factors. So among the 148 patients assessed, the prevalence of MET syndrome was about 50% according to IDF criteria and 38.5% according to NHLBI criteria. And for both classifications, the independent factors associated with metabolic syndrome are older age, shorter time since transplantation, and history of excessive weight prior to the liver transplantations. So other predictors for METs according to IDF were alcohol abuse, physical activity reduction as the cause of weight gain after the transplant, and calcium intake below recommended levels. The presence of METs according to the NHLBI criteria was also associated with a decreased intake of potassium, fiber, and folic acid. So these are the nutritional requirements for those who are requiring transplantation, before transplantation, immediate after the transplantation, and for the long-term transplantations. So you can see here in terms of the protein-wise, energy-wise, it depends on nutrition status and the losers. So it is usually 20-25% above the basal requirement for pre-transplant, and for the immediate post-transplant, it is between 20-30%. And for the long-term transplant, post-transplant, it is usually 20% above the basal for sedentary activity if the weight, if the patient reach the goal weight. Okay, and then for the protein, for the pre-transplant, it requires 1 to 1.5. For immediate post-transplant to promote wound healing, it is between 1.2 to 2.0. And for the long term, to promote the maintenance of the nutritional status is about 1 gram. And then for fat, pre-transplant is what is needed. And then for the immediate, it's about 30%. And it is also the same as seen in the long-term post-transplant. And for the sodium also is the same throughout the process. For fluid, restrictions are needed if the patients experience hyponatremic prior to the transplantation. And for the post-transplant, it is as needed according to their body weight. Okay, and then for the calcium intake, it is between 800 to 1,002 for both pre and also immediate post-transplant. And for the long term, it can go up to 1.5 grams. And for vitamins and minerals, it is according to the DRI. So next, we proceed to the disease of exocrine pancreas, which is pancreatitis. It is characterized by a loss of intracellular and extracellular compartmentation, which there is an obstruction of pancreatic secretory transport and also activation of some of the pancreatic enzymes. So these are the etiology of pancreatitis, which are genetic conditions, viral infections, certain drugs use, hypertriglycemia or hypercalcemia, biliary tract disease, chronic alcoholism, trauma at the sites, and also gallstone. So according to clinical findings, these are the symptoms that the patients could always experience, okay, which the onset of pancreatitis can bring severe abdominal or back pain, which is the most acute when the affected patient have to lie down on his back, okay? And the symptoms of pancreatitis can range from continuous or intermittent pain of varying intensities to severe upper abdominal pain, which may be radiate to the back of the patient, okay? And the symptoms may be worsened with the ingestion of food. So normally they will most likely to be feared to consume certain type of foods, and that's why this also could contribute to poor nutrient intake and therefore could contribute to poor nutritional status. And other clinical presentations that could they experience like nausea, vomiting, abdominal distension, and also staturia. In severe cases, it is complicated by the presence of hypotension, oliguria, and also dyspnea. So the diagnosis is depending on two types of diagnostic tests, which is using the Ranson's criteria to predict the severity and mortality of the disease, and also using various tests of pancreatic functions. So this one is a Ransom criteria, which during the admission, these are the criteria that the healthcare professionals should be looking for to assess the severity of the disease, okay, which is depending on the age, white blood cell, blood glucose, serum LDH, and also AST. And then during the first 48 hours, to see for if there is any decrement of the hematocrit level, BUN, serum calcium, arterial PO2, and also is there any development which indicate worsening of the prognosis. And this one are the tests of pancreatic functions like the secretin stimulation test, glucose tolerance test to assess endocrine function of the pancreas by measuring the insulin level, okay, and then 72 hours stool fat test to assess exocrine function of the pancreas by measuring fat absorption, which reflect the pancreatic lipase secretion, and fecal elastase. So this enzyme is most commonly used to determine pancreatic function. So if the levels is more than 200 micrograms, so it is considered normal. If it is less than 15 micrograms, meaning that the patient experienced pancreatic exocrine insufficiency. So for the nutrition assessment, we can use the weight, height, the normal one, and then biochemical profiles, Ransom criteria, and also NRS, which is the nutritional risk screening 2002. So these are the abnormalities that can commonly found for the pancreatitis patients, which hypocalcemia, hypoalbuminemia, increase in the serum amylase and lipase, hyperglycemia, leukocytosis, and increase in the CRP, which suggests that there is a pancreatic necrosis and are the causes of low albumin. So for the MNT is depending on acute and also chronic pancreatitis. So for acute pancreatitis, early oral feeding should be initiated, which we should give them a low-fat diet, soft or solid consistency depending on the patient's ability, okay, and then to withhold oral feeding if patients experience pain, vomiting, and also ileus, and to support with IV fluids. So if oral feeding cannot be initiated in 5 to 7 days, it should start with tube feeding. So once the oral feeding is tolerated, always recommend easily digestible food, low-fat diet, 6 small and frequent meals, adequate protein intake, and also increased calories. For a severe acute pancreatitis, which at this point they are in hypermetabolic catabolic state with immediate metabolic alterations in the pancreas, so they will exhibit signs of stress-induced malnutrition, as you can see from the level of albumin, transferrin, and also lymphocytes. Okay, so this one is not necessarily saying that they are malnourished, but this actually due to the stress or inflammation, and these are associated with significant morbidity and mortality. So they are most likely to develop other complications such as cirrhosis, fluid collections, pancreatic necrosis, multi-system organ failure as well. So this is the route of nutrition treatment in acute pancreatitis. So the severity assessment of acute pancreatitis, so whether it can be classified as mild, moderately severe, and also severe acute. For mild, it can be advanced to solid oral diet, and for moderately severe acute pancreatitis, can opt to whether on-demand oral diet if it is a non-ICU case. But if the patient do not tolerate within 3 days, so it can proceed to enteral nutrition via nasogastric or tube within 40 hours. And for it is also applied for severe acute pancreatitis, which should be proceed with enteral nutrition. So if the patient is tolerated and improve their clinical status, so it can be then advanced to solid oral diet. But if the patient does not tolerate, so from the NG tube is proceed to the NJ tube, nasojejunal tube. But if the patient cannot tolerate again, so it is then proceeded to parenteral nutrition. So which type and route of enteral nutrition is required? So NG tube feeding is always feasible, safe, and well tolerated. So this one is easier to place, more convenient and cheaper with less complications compared to NJ and also TPN. And then the types of formula that you could use is that whether the standard polymeric diet or if the patient is having impaired functions in terms of the digestion, okay, so you can introduce the semi-elemental diets, okay. And for chronic pancreatitis, so the risk of malnutrition in chronic pancreatitis is high, and malnutrition is common among them. So these are the risk factors that could contribute to malnutrition among the CP, like alcohol abuse, smoking, diabetes mellitus, inadequate oral intake, abdominal pain, and also pancreatic insufficiency, which could have a problem in terms of the digestions of certain nutrients. And then for the nutritional assessments, for the anthropometric measurements, you could look for any changes in the body weight, the functional assessment to the hand grip strength, and then skin fold thickness, waist circumference, and mid-arm muscle circumference to see for any signs of muscle loss and any presence of ascites or edema. And for the biochemical assessments, look for the level of fat-soluble vitamins, PTH, and then screening for the anemia, for the iron, cobalamin, folate, ferritin, and also CRP, and also their glycemic control as well. For the symptom assessments, you should look further into their dietary intake if there are any changes in terms of their appetite, presence of any symptoms that could impact on their oral intake like nausea, pain, indigestion, early satiety, and then presence of exocrine or endocrine dysfunction. And for further examinations, which can use CT scan or DXA, to determine the bone mineral density, and for the CT scan to determine for any muscle mass loss. So the dietary recommendations for them, the normal nutrition status should adhere to a well-balanced diet. For those who are malnourished, they should consume high protein and high energy food in 5 to 6 small meals per day. High fiber diet is not always recommended for them, and there is no need for dietary fat restriction unless there are symptoms of steatorrhea and cannot be controlled. So ONS or oral nutrition supplement can be prescribed for them, and also macronutrient supplementations. So in terms of the selection of types of enteral nutrition and when should be given, nasojejunal route is the is one of the route that is recommended, okay, for the administration of the enteral nutrition. And then it should be opt for standard formula. But if the patient cannot tolerate well, so semi-elemental formulas with medium chain triglyceride can be used. And then pancreatic enzymes can be given to the patients if there is a sign of exocrine failure. For TPN, okay, so total parenteral nutrition. So it is indicated for chronic pancreatitis patients who have other symptoms like duodenal stenosis, complex fistulization, or malnourished patients with GI dysfunction prior to the surgery. So the placement of the CVC or the central venous catheter will be placed at the internal jugular or subclavian, and it may be required if an ileus is present or if patient has been NPO for 7 to 10 days. NPO to meaning that the patient is not given any food through orals, okay? And even kalau daripada IV pun hanyalah a normal IV, okay? And for it is invasive and should not be used for very early in pancreatitis, but there are high risks of catheter-related infections and also sepsis, and patients also could experience metabolic disturbances such as hyperglycemia due to overfeeding. So prolonged TPN may suppress the immune system, promote the GI leakage by a loss of intestinal mucosal barrier with the potential risk of subsequent bacterial translocation. So other treatment that can be used to treat pancreatitis is pancreatic replacement therapy. So it is to treat pancreatic exocrine insufficiency, which is defined by insufficient secretion of pancreatic enzymes and or sodium bicarbonate. So the clinical signs are steatorrhea, flatulence, bloating, dyspepsia, urgency to pass stools, and abdominal pain or cramping. So a pH-sensitive enteric-coated microsphere pancreatic enzyme replacement shall be used in treating PEI. So oral pancreatic enzymes should be distributed along with meals and snacks. So the efficacy of this PERT should be evaluated by the relief of GI symptoms and the improvement of nutritional parameters, which can be seen from the anthropometric measurements and also biochemical tests. So the nutritional prescriptions for chronic pancreatitis, energy, it is between 25 to 35 for protein, 1.2 to 1.5, and then for the carbohydrates, 3 to 6 grams per kilogram body weight per day, and for lipids up to 2 grams per body weight per day. Alright, so that's all for the MNT for liver. And is there any questions from the floor? Any questions?
Tak ada, doktor.
Alright, so tomorrow we'll cover another one chapter from my part, and then for test will be after Raya, okay? And tomorrow also during tutorial I will put up learning activity, so please ensure that you allocate that 1 hour to answer the tutorial. Okay, so if there is no questions from the floor, so thank you everyone and hope to see you next week. And those yang nak balik kampung tu, selamat balik kampung.
Thank you, doktor.
Thank you, doktor. Thank you, doktor. Assalamualaikum.
Habis anak dah habis.